I'm Leanne Gensler. I am one of the moderators today for the virtual rheumatology learn collaborative session hosted by the ACR. I'm a rheumatologist at UCSF in San Francisco and the program director there. And welcome everyone to the session today. I'm going to let my co-moderator introduce himself.
Hi, my name is Rami El-Tarabolsi. I'm a second-year fellow at University of North Carolina in Chapel Hill. Thanks for having me.
And we're excited to host this session today. I certainly am looking forward to learning from Dr. Pike. Dr. Pike is an assistant professor of medicine in the Division of Rheumatology at Johns Hopkins University School of Medicine. She's also the director of clinical trials at the Johns Hopkins Myositis Center, and her research focuses on the overlap of myositis and novel therapeutics in myositis. And we're really excited to hear from you today, Dr. Pike. Let's get the session going. Let me make a couple of housekeeping points before we start. There are a couple of functions of the platform you should know about. If you have questions, and we really encourage you to use that icon in the bottom, the Q&A, to populate it with questions, which we will then moderate at the end of the session and have Dr. Pike answer them for us. There's a chat function if you just want to make a general comment, not a question, to everyone that everyone can see. And there was a raise your hand function, which is for technical support, and ACR will help you there. Thank you. Let's get started.
Great. Hope you can hear me. Great. Thank you for the introduction. Pleasure to be here. I will be discussing myositis therapies today. These are my disclosures. So the outline of my talk today is first to give a brief overview of different subgroups of myositis, and also give you a breakdown of how I evaluate myositis. Then I will delve into the treatment algorithm of myositis that we know of and that's in the literature. And then I will go through 3 cases of myositis and interweave that treatment algorithm into each case, and then highlight some promising treatments in myositis. And please let me know if you can't hear my voice, because I'm not sure if I'm too distant from the computer, but let me know through the chat.
Julie, we can hear you fantastically.
Okay, great. All right. Okay, okay. So first I'll talk about the evaluation of myositis and how I approach a new patient in the myositis center. There are 6 clinical features that we look at and tools that we look at. The first is really the pattern of muscle weakness. Is it proximal and distal, or is it just proximal? And usually our patients with myositis will have proximal weakness by itself, but certainly patients with IBM, which is another subgroup of myositis that I will not be talking about, can have proximal and distal weakness. The second is the muscle enzyme elevation. Of course, normal CK is less than 200. Normal aldolase is about 8.1. And normally, you would see some elevation in the CK. Patients with immune-mediated necrotizing myopathy typically have CKs that are very high, 10,000, 15,000. The highest I've seen is about 75,000. So that will give you some hint to, if you're just looking at the CK and you haven't even seen the patient, then you may get a sense, oh, this patient probably has a necrotizing myopathy. The third would be an EMG or nerve conduction study, and I will go into that in the next slide. The fourth will be the MRI of the muscles. I know you can't get in everyone, but I think it is very helpful to assess activity and also chronicity of the disease. Fifth is the muscle biopsy, and we know that different subgroups have distinct muscle histopathology, and so that does become very helpful, especially in patients where you're being asked to see, is this truly polymyositis? And certain times it's going to be refractory polymyositis, and maybe it's actually IBM and the biopsy missed it initially. So the muscle biopsy can be very helpful as well. And last is the autoantibody or the myositis autoantibody panel that we can order. And I will get into that in the next couple slides as well. So why is the EMG nerve conduction study important? The main reason is because it helps us when someone is very weak and you're trying to figure out the reason for the weakness. It's important to determine, is the patient having muscle weakness from an intrinsic muscle process, a myopathic process, or is the nerve contributing to muscle weakness? Because obviously the nerve communicates to the muscle, and if the nerve is injured or damaged in some way, you're gonna also have muscle weakness. So here in normal muscle tissue, what will happen is that you have the normal motor neuron and axon feeding into these motor fibers, muscle fibers. And once you put that needle into the muscle, when a neurologist does it, you should have a normal motor unit action potential here. But in patients who have a muscle problem, in myopathies, you'll actually get this dropout of the individual muscle fibers here. And when that happens, when you put that needle in the muscle, you're gonna not see a very large response. You're gonna have much shorter, or we say shorter duration, or polyphasic and low amplitude of the motor unit action potential. So that basically tells us, is it a myopathic process if you see these smaller units? And then also on the EMG report, you want to also look for the positive sharp waves, we say PSW on that sheet should be mentioned, and fibrillations. And those two key features on the EMG report, when you're looking at it, will let you know if there's evidence of more irritability in the muscle, indicating that it most likely is an inflammatory myopathy. About 40% or more will have an irritable myopathy on the EMG report. The next tool that we use is the MRI of the muscles, and we typically make sure we order the T2 stir images here. And the reason why we do this is for the stir images, these are the two sequences that are most important. The stir images give us a sense of the activity of the disease. So edema will look very bright here, as you can see, and normal muscle tissue should be dark. So if you see this degree of edema, you know the muscle is very inflamed and active. Now remember, the MRI never truly diagnoses a myositis, because certainly if someone had a severe radiculopathy and they have, or impingement, you will see some muscle edema in the posterior compartment, and then you might say, oh, this patient has myositis, but you really can't diagnose myositis on an MRI. It's just getting a sense of where the degree of edema activity is, and it could also show here, I want to give you here, this is also where this light white is around the muscle, that's also fasciitis. So we see a lot of fasciitis typically in patients with dermatomyositis. And it's quite obvious. And remember, the normal anatomy, I should have said this before, is that you have a skin on top and you have the subacute fat, and then you have the fascia, and then you have the muscle. So the fascia is the area that won't give you a lot of leakage in the CK in the blood, but you can get somewhat muscle pain. And you can see it clearly on the MRI, which is very easy to demonstrate here. So that's activity. For fatty replacement, we look at the T1 sequences. And that is important, especially in chronic myositis, or if you're seeing a new patient, they've had the disease for a long time, chronic myositis, you want to get a sense of how much damage has this patient already incurred from their myositis. And here, this is normal. And there's not a lot of fatty replacement, but you can see here the muscle has turned into fat. Now, when you treat the muscle disease, it will regenerate, right? And you can get the inflammation down, inflammation will be gone. But if you didn't give the appropriate treatment, or it's a genetic muscle disease that there's no treatment for, like an adult onset muscular dystrophy, then what's going to happen is the muscle will turn into fat. And once the muscle is completely changed into fat, there's nothing we can do to unfortunately reverse that. So that tells us chronicity and damage. The muscle biopsy is important because, as I mentioned before, there's distinct histologic characteristics of each subgroup of myositis that we typically see in the clinic. This is an example here of a normal muscle biopsy, and you can see the nuclei are on the outside, very healthy looking. The myofibers are all the same size in this fascicle. I hope you can see here, this is very abnormal, and this is an example of a necrotizing myopathy. And you can see the myofiber size is different, and also you can see here these muscle fibers are undergoing necrosis. Here's another example of perifascicular necrosis, which is it's increasingly being understood as a distinct feature of antisynthetase syndrome. So that would be something you might want to look out for on muscle biopsy if a patient with, for example, polymyositis with JOL1 happened to get a muscle biopsy with lung disease. And lastly, the myositis autoantibodies are helpful because we know that they have distinct clinical phenotypes, and they're very helpful in helping us put patients in certain subgroups. And in fact, and I'll go to the next slide, but sometimes, in fact, we wonder do we really need a muscle biopsy if we have a patient who is HMGCR positive high titer. I mean, it's invasive. We already know that patients who are HMGCR will have a necrotizing myopathy. Their CK 16,000 is really going to change management. So there's some debate about that. But as you can see here in this IMNM, or the immune-mediated necrotizing myopathy, the two key autoantibodies we think about is SRP and HMGCR. Those with lung involvement, typically we think about antisynthetase and MDA5. And then, of course, there's this overlap because patients with dermatomyositis can certainly have lung involvement in MDA5 as well. And the more prominent skin diseases, SAE and MI2, MI2 tends to have a better response to treatment. And NXP2 and TIF1 are the ones that are classically associated with a malignancy. So just in brief, the ones that I'm really going to be focusing on today are the ones that we know that there's more treatments on. So first is dermatomyositis. Remember, if we think about that evaluation that I mentioned before, they have proximal muscle weakness. Their CKs tend to be elevated. Well, although I have to give you an example that some of my dermatomyositis patients may have a CK of 200 or 300, and they can actually be quite weak. So it doesn't always fit the bill that you have to have a CK of 2,000 to be very weak. And of course, the classic GO-TRINs and the heliotrope. And on muscle biopsy, you're going to see the perifascicular atrophy. And you can see these fascicles. But here, these muscle fibers right here at the perifascicular region are atrophied. And so this is very diagnostic of dermatomyositis. Begs the question, remember I mentioned muscle biopsy, is it really needed, especially if someone has an autoantibody? And the other case where we think about, do we really need to have a muscle biopsy in a patient with full-blown, V-neck, Holster sign, everything? I don't know if you really need to have a muscle biopsy to prove that this patient has dermatomyositis. Immune-mediated necrotizing myopathy, again, you're going to see the necrosis of the muscle fibers. Always want to ask about statin exposure, and they're going to have this proximal muscle weakness. And polymyositis, I put this in here because it's really becoming a diagnosis of exclusion. Actually, our director of the Myositis Center, Lisa Christopher Stein, had a great debate in our IMAX, myositis kind of international consortium we had recently at ACR with Dr. Fred Miller. And I think it was interesting because a lot in the international community, a lot of people wonder if polymyositis really exists. And the reason is because most of the time it could be something else. So it really should be a diagnosis of exclusion. You want to make sure you're thinking about thyroid disease. Is it an adult onset muscular dystrophy, or other toxic medications? So don't forget that if you have somebody in the clinic that comes in with polymyositis, you really want to get a muscle biopsy in these type of patients. Okay, so now I'm going to change gears and talk about the treatment paradigm of myositis. It's not perfect. It's not like we have multiple clinical trials like in cardiology for ACS and things like this. But what we know from the current data is that these are the type of treatments that we usually use in our new patients in the clinic. So first and foremost, we're always going to use steroids. And steroids in the clinic setting would be prednisone, 1 mg per kg. I hardly ever go over 60 milligrams per day. And you want to start it at the same time as either one of these 3 steroid-sparing agents. And it's hard to decide which one are you going to use first. Is it going to be methotrexate, azathioprine, mycophenolate? And unfortunately, all the studies that have already been conducted in the past, mostly case series, there's no randomized controlled clinical trial showing which one is better. So what I really do, what we really do is looking at the other organ manifestations that typically do happen in our patients can also guide us to decide which steroid-sparing agent I'm going to start at the same time. So for methotrexate, if they have concomitant joint involvement, which is not uncommon in JO1 disease, in one of the largest cohort of anti-JO1 patients, they found that up to 30 to 40% will have actually inflammatory arthritis at the onset of symptoms. So as long as you're monitoring their lung function, they're not having severe ILD, I mean, methotrexate can be a consideration in those JO1 positive patients or anti-synthetase or any of the forms of myositis I'm going to be talking about today. Azathioprine, certainly if they have more lung involvement, I'll be using that. And mycophenolate will also be used if they have more lung involvement as well. Now, how do you determine if you're going to use azathioprine versus mycophenolate? That's a hard question. In our kind of expert experience or our general experience at the Myositis Center, we have noticed, and there's some case series to support this, that CellCept tends to work a little bit better for skin disease in our experience, and so I think we tend to use mycophenolate more in dermatomyositis patients, but it is not a definitive rule. So these things can help you to determine which one you're going to start first. I do want to put this slide in because I feel this is it's an older study, but it was an oldie but a goodie. So I say it was a random crossover study where they looked at steroids plus methotrexate. And if you were on methotrexate alone or azathioprine alone and you didn't have a good enough response, then they would add azathioprine to your drug. So for example, you're on steroids and methotrexate and you max out the methotrexate, you're still not getting the best response for your patient, then you could add low dose azathioprine. And these patients tended to do better on combination therapy. And so I think this is something that we do a lot in myositis. We do use a lot of combination therapy, and we shouldn't be scared to use it. I think we just have to carefully monitor them. Okay, so beyond oral agents, if a patient is not responding, then we're going to start adding IVIG or rituximab. And so again, once you start the steroids plus one of these 3 steroid-sparing agents, then after about 3 or 4 months, you're going to see a response. If you don't see the response, then you're going to start adding IVIG or rituximab. And IVIG, based on the seminal study by Delakias in 1993 in the New England Journal that was published, for dermato, that's kind of, it was a dermatomyositis study, but that's the dose that we use in all the forms of our myositis. So it's going to be 2 grams per kilogram IV given over 2 to 5 days. Usually I start over 5 days initially because of the fluid load and making sure the patient doesn't have a headache and all these side effects. And then, or rituximab based on the RIM study. Although it didn't meet the primary outcome, when you go back, the patients who had the most post-hoc analyses showed that patients who had the best response were those who had an autoantibody. So the other clinical features you can use really is if someone has a dysphagia, then you're really going to move to IVIG really quickly. So if the patient is in the hospital, and because so far I've been talking about like an outpatient clinic setting, but if you have a patient in the hospital, then you're probably going to be using IVIG from day 1 if they have dysphagia, and that was the reason for their admission. And then certainly if someone has RA on top of it, like I was telling you, inflammatory arthritis, that can be a very concomitant manifestation we see in our myositis patients, then we can also use rituximab to treat them. But also, as I mentioned, the RIM study, post-hoc analyses of the RIM study show that people do respond, especially those who have an autoantibody. Okay, so now I will be going into the case discussions. So first case is a patient, a 60-year-old male with muscle weakness. So this patient had used atorvastatin for about 3 years, and he developed progressive muscle weakness for 2 months. His primary care checked his CK, and it was 5,000, and the atorvastatin was stopped, but now the CK is more than 15,000, and he has dysphagia, and he cannot walk without assistance. And remember, it's proximal muscle weakness, and so we always check these 3 muscles all the time in our patients. And and focus in on those muscles, the neck flexors. And remember, you really want them to be lying flat. And then you have them, without or below, and you ask them to lift up their head and you push back. So this patient had 2 out of 5, and the hip flexors were 3 out of 5, arm abductors were 3 out of 5. And the EMG showed an irritable myopathy. Remember, so they had myopathic features, but when we're talking about irritable myopathy, you have presence of positive sharp waves and fibrillation on the EMG. And the MRI showed evidence of this type of example that I showed you previously, where there's a significant amount of muscle edema on the T2 stir. And if you didn't already guess, this is immune-mediated necrotizing myopathy, and you typically see necrosis of the muscle fibers, degeneration, and regeneration with no inflammation. No inflammatory cells, actually, typically. So this was first described by our director of the Myositis Center, Dr. Lisa Christopher Stein and Dr. Andrew Mammon. It's a statin-associated immune-mediated necrotizing myopathy. So they looked at patients who had necrotizing myopathies, and they found that they had a distinct autoantibody, these autoantibodies against HMGCR. Because it was discovered at our center, we do have a large number of these patients, which gives us a special opportunity to look at the longitudinal follow-up of these patients. So my colleague, Dr. Eleni Tiniakou, looked at about 104 patients in 2017, and 50 patients had more than 2 years of follow-up. Only 22 of 50, or 44%, reached full strength with immunosuppressive therapy. And even those with recovery of full strength, 55% had a CK greater than 500. And this is important because I do get the question a lot of, especially in our necrotizing myopathy patients, their CK was 15,000 and we treat them, they're getting strong, they're jogging again, and I have patients like this. And their CK number really goes back fully to normal on immunosuppression, but they're doing everything they did before. So this is not uncommon. We really just kind of follow the CK, but their clinical improvement and clinical stability is more important. So these patients also tend to have a higher relapse rate. So you can see the 40% didn't reach full strength. And our necrotizing patients, I would have to say, are overall much harder to treat in a sense that they may be responding to a drug beautifully for a while, and then they suddenly flare, and then it's much harder to get them under control. So, really we're aggressive about treating them early on. And another interesting finding we found was that patients tended to be older at disease onset, and they were stronger at all time points if they were diagnosed early. So going back to that treatment paradigm of myositis, if I'm seeing this patient in the outpatient setting, and you have a spectrum, right? It's heterogeneous. In the world of necrotizing myopathy, you're gonna have patients who are extremely weak, and they're coming into your clinic in a wheelchair, and you're admitting them to the hospital. Versus, I do have a handful of patients who are elderly, but for some reason, or young, for some reason they're not that weak. So they're like 4+ out of 5, 4+ out of 5 in the neck flexors. So I still would treat them with an oral steroids and oral steroid sparing agent here, as I outlined. Choose one, typically methotrexate, because it's, you take it once a week. And then I will consider, if they don't respond, adding either IVIG or rituximab. Now I'm going to go to the next slide. So most important thing is the degree of weakness. He just gave you 2 examples. You have one patient who's extremely weak, and then one patient who may not be. So really, what's driving my decision point in going straight to the IVIG infusion therapies early on would be the degree of weakness. So I am going to touch a little bit on IVIG. There are no randomized clinical trials of IVIG yet, but for specifically for HMGCR or immune-mediated necrotizing myopathy. But my colleagues, Dr. Mammon and Dr. Tiniakou, did report in the New England Journal in 2015 of 3 patients who had diabetes and declined steroids, and just using IVIG monotherapy, these patients had a beautiful response. So I know it's a case series, but it does highlight the efficacy of IVIG in these patients in monotherapy. So the patients all had very high CKs here, CK of 8,000, 3,000, 2,000 patient. And then The strength was 4 out of 5. And you can see here within even 1.5 months in this patient 3, the CK dropped to 738 from a CK of 3,517. And in patient 2, the CK was 2,000 and went to 270, close to normal, less than 200. And in long-term follow-up, you can see that these patients continue to have a response to the IVIG with low CK. Strength-wise, they also had improvement in their CK, which is remarkable. So I think this highlights basically that IVIG may be, and we see this in the clinic, I think there should be more robust studies to look at this, but we do use it and we see a really good response in these patients. So IVIG, if I had to choose a next diffusion therapy, would be IVIG for these patients. Okay. So case 2 is a 47-year-old female with refractory dermatomyositis, and she has a skin rash and weakness on methotrexate, max dose of 25 milligrams per week, and IVIG 2 grams per kilograms IV every 4 weeks for 6 months. And the strength is 4 out of 5 arm abductors and hip flexors, and she has a shawl sign, as you can see here, and the Gautrins papules. The CK is 220, Adelaide's 10, and her antibody is positive for TIF1 gamma. So overall, I would classify her as the skin predominant refractory dermatomyositis. I do want to highlight TIF1 gamma has a much higher risk of cancer associated with it. This is an elegant study done by the Japanese cohort where they looked at their myositis cohort. And of the 349 patients, 21% were cancer associated. And of the 75, 48% were TIF1 gamma positive. And as you can see here, their diagnosis of cancer was typically within the first year, about 97%. These are in green, TIF1 gamma positive. And the 3 most frequent cancers were gastric, lung, and breast. So the overall kind of phenotype of these patients that have been published are patients who have more extensive skin disease. And this was reported in Dr. Fiorentino's group, and he has one of the largest cohorts of dermatomyositis patients. And they're less likely to have ILD, Raynaud's, or arthritis. But as I mentioned, because of that cancer risk, if someone is not responding in terms of their skin disease or their muscle disease, typically in these patients, because they don't typically have ILD, you really want to make sure that they do not have a cancer that's driving their disease. So we always make sure in our new patients to get age-appropriate malignancy screening, especially mammogram and pap smear, and then at least one time CT chest, abdomen, pelvis, or a whole body PET CT. So here is kind of my algorithm for skin predominant treatment of dermatomyositis. So again, you're going to be using steroids plus one of these 3 agents, methotrexate, mycophenolate, azathioprine in this left box, and then plus or minus IVIG. Now, I did mention IVIG before, the main seminal study done in 1993 by Dr. Delakis really looked, it was a placebo-controlled trial of IVIG, but it really looked more at muscle involvement as a primary outcome measure. But you can see here, even in 1993, this picture highlights the improvement in the skin rash. So we do know IVIG does work for skin as well. And rituximab doesn't work for skin. We know that the RIM trial, as I mentioned before, looked at a composite score of definition improvement, but if you actually look only at skin as outcome, post hoc analyses done by Dr. Agrawal in 2017 shows that patients who have skin involvement also have improvement. And usually the median response time was about 16 to 20 weeks post rituximab. So this can also be used for the treatment of skin predominant dermatomyositis. I think it's an exciting time for clinical trials in dermatomyositis, especially. One that is the closest to kind of potentially getting FDA approval, the first FDA approval for dermatomyositis would be actually linabazine. This study was pioneered by Dr. Vicky Werf at UPenn and also Dr. Barbara White at the Corvus Pharmaceuticals. But basically, in their initial phase 2 study, which was done in 2017, they found that patients given a cannabinoid receptor 2 agonist had a really good response in terms of their skin disease. And you can see here, compared from visit 1 to visit 6, this rash here, the sleeve sign we call, was gone. And in the V-neck is mostly completely resolved. So their primary outcome in that phase 2 was this cutaneous dermatomyositis activity, severity, and severity index, which is only looking at skin activity. Now, of course, if you want to go to the FDA for phase 3, you're going to have a better composite score. So now there's an ongoing phase 3 that's a multi-center international study where we are also a recruiting site where they are looking at placebo and 2 dosing arms. And I think this will be, it's a very promising study. Now, I do have to mention the caveat with this drug is that they do allow, and they will adjust this for the analysis, but they do allow concomitant drugs, meaning you could be on stable IVIG and CellCept, and then you add on linabazine. So I think this will be a promising study. You'll hear more about it in the future. Some other trials that are going on in dermatomyositis would be abatacept. It was PM and DM combined, really had up at the Karolinska Institute in Sweden. It was an open label pilot study of 19 patients, and 42% met this definition of improvement. It's like a composite score that we look at in clinical trials at 6 months. So the phase 3 trial has started. And there is an investigational drug called anti-interferon beta. We do know that interferon signature is highly upregulated in patients with dermatomyositis in the muscle and the skin. It's been reported. And so this is a randomized placebo-controlled trial. It's a phase 2. We were also a recruiting site. And the primary endpoint is really just skin again. So I think this will also be something to be on the lookout for in the horizon. Another study class of drugs that we looked at were JAK inhibitors. Well, the first drug or report of a JAK inhibitor working in dermatomyositis was in the New England Journal in 2014 and in Germany. And it was a 72-year-old woman who had dermatomyositis but also had myelofibrosis. And it was a very kind of recalcitrant or refractory disease. And they gave her ruxolitinib. And the thought was, oh, potentially it was this drug was blocking interferon beta activity and also regulating the dendritic cells and the T lymphocytes. But there was also, after this case report was published, a lot of responses about potentially was, well, you're treating the myelofibrosis, so maybe that's actually the reason why I was responding. And so, of course, once that came out, there were multiple other reports, including ours, of tofacitinib. At the time in the US, that was the only US JAK inhibitor that was available and because it was FDA approved for rheumatoid arthritis at the time. And that was also looked at in a dermatology clinic at Harvard. And they saw that these patients with refractory skin disease had some improvement. And incidentally, I actually had my own patient who had failed multiple agents, including rituximab and IVIG, and multiple steroid-sparing agents, who also developed, and these patients, evolved, developed inflammatory arthritis. And that was the only reason we actually put the drug on her, and she had a remarkable response. And so we also reported this as a case. That ultimately led to, because I was really quite astonished by the response in the skin disease. In fact, I remember her telling me that she went to the beach for the first time in many years because her skin looked so good. And I was like, why did you do that? Did you put on the SPF? But she was a quite remarkable case. And that also led with other patients that we saw in our center to approach Pfizer and do a study with them. And it was just a proof of concept study. We called it the study of tofacitinib in refractory dermatomyositis, DERS study. And basically, there's a screening period and they wash out. Actually, so when I designed this, I said we want to really look at the efficacy of this one drug only, to be a kind of sort of a purist. And they washed out of their steroid-sparing agents and IVIG because really it's not even working. We did allow prednisone at entry, but anyways, the weekly intervals that we assessed were week 4, week 8, and week 12. And that was our primary outcome. And they were given, at the time, TOFA came out as long extended release. And so for compliance, they were given just 1 tablet a day. And they were also given the option to extend the drug if they wanted. Oh, and also we did enforce a prednisone taper to assess the efficacy of TOFA by itself without steroids. Okay, so the results, so we only had 10 patients, and their mean age was about 45. They're mostly female, about 70%, mostly Caucasian, 90%, and years since symptom onset was 6.45. So they had chronic disease, and they weren't responding. So it was really treatment refractory patients. And only 4 out of the 10 were required prednisone because of the taper or washout of the other steroid-sparing agents, so about 40%. And you can see here, I'm going to highlight in this red, is that their mean CDASI, which is basically the skin assessment, how active and red their skin is, was about 28. And it's a validated skin assessment developed by Dr. Worth. And it actually, if you have at least a score of 14 or higher, it means that they have moderate to severe skin disease activity. So certainly our patients were enriched for really, really active skin disease. The mean manual muscle testing was not very low. So this is like assessment of muscle strength. And normally, you want to have less than 140 to say you're really weak. So these patients were not very weak at all. And that's also further supported by the CK being around 82. So the results overall were that all 10 subjects met the primary outcome of interest, definition of improvement at 12 weeks. And we also looked based on the myositis response criteria that was validated in 2016, this total improvement score was also calculated. About 50% had moderate improvement and another 50% had minimal improvement, and the median total improvement score was 40, indicating that at least there was moderate improvement all across the board. And you can see here in this box plot is a nice gradual decline of the CDASI, which is the skin assessment score, at baseline at the median of 20. And by week 12, it was close to 10. And this was statistically significant when you look at week 12 and baseline. Here are some examples of one of our patients who had a significant response. Her skin was quite active. You can see here there's intense erythema in the back, and this here was quite itchy, the shawl sign. And she had a little bit left over, but this was completely resolved. Again, in the V-neck sign, very erythematous, itchy, and this was mostly resolved by week 12. Some of the other exploratory endpoints that we looked at were, we looked at autoantibody profiles, and 7 subjects were TIF1 gamma, not surprisingly, because as I said, they were more skin predominant disease. 5 out of the 7 or 71% were moderate responders, and 2 of the 7 were 29% were minimal responders. And remember I mentioned we did enforce the prednisone taper. Now, of course, if they could follow the taper that we had outlined, we did give you rescue therapy. 40% were at 20 milligrams daily entry, and 3 out of 4 were able to completely taper off all steroids. Now, so JAKs are also getting a lot of interest in juvenile dermatomyositis. And a colleague of mine, Dr. Kim at the NIH in the pediatric myositis unit, also presented an abstract recently this past year at ACR where she did use baricitinib and added that drug to other concomitant steroid-sparing agents in juvenile dermatomyositis patients. And as you can see here, the CDASI activity score definitely went down by week 24, most of the patients. And also the MMT8, which is a measure of a patient's muscle strength that we use in clinical trials, also improved in 2 out of the 4. And so I think it's a promising treatment even in juvenile dermatomyositis. There was also one case report in Europe as well of this patient. Now you might not be, oh, maybe this patient doesn't have severe skin disease, but in reality, this patient had quite severe skin disease. And he's only 11 years old, and he was even on Cytoxan, when you read this case report. And tried everything. We're talking about IVIG, and basically baricitinib was also used, and the patient had a really good response. So not surprisingly, I am aware that there is a MyoJAK study that's going to be started in Europe. They're going to be using baricitinib, to my knowledge, in Europe as a clinical trial. So I think this JAK inhibitors we will be seeing more of in the dermatomyositis world. So going back to this kind of treatment algorithm I mentioned for dermatomyositis, I think linabazim, abatacept, and JAKs are on the horizon, and some promising treatments that we can see in dermatomyositis. So case 3 is a 54-year-old male with shortness of breath and rash. This is actually my patient. I remember when I started a fellowship over 10 years, about a little bit over 10 years ago. So vacationing in Florida, developed sunburn, like rash and V-neck sign, heliotrope, and within 2 weeks he developed cough and shortness of breath with exertion. He was treated with levofloxacin for presumed pneumonia, no improvement. He was prescribed steroids, but it just progressively, rapidly declining, significant worsening of shortness of breath in 2 months. And you can see here, this is his baseline CT, and within 2 months, this degree of interstitial lung disease. And I remember when I met him, he was on ECMO when I was a first-year fellow, and he unfortunately did not make it. But I think these patients leave an indelible mark in your career path, where you think about what inspires you in trying to find treatments for these patients. So this patient had MDA5 associated dermatomyositis, and he was really, most of these patients have clinically amyopathic dermatomyositis. And, he really had those kissing papules, we say, on exam, I remember, and he had some dorsal ulcers and only very mild, heliotrope. You really have to look carefully, and mild periungual erythema. And so these patients, you might not be so impressed with their dermatomyositis skin-wise, but they have rapidly progressive ILD. So the distinct cutaneous features, these kissing papules here, as you can see, the flexor surfaces of the fingers, and you get these dorsal cutaneous ulcers, and they tend to be more difficult to treat, these ulcers. So we looked at MD5 associated dermatomyositis in our cohort, and about 160 patients with dermatomyositis were looked at. And at the time, only 11 were positive for MDA5. But interestingly enough, 9 of the 11, 81% had symmetric polyarthritis. And that might not be on your radar of patients who have MDA5, but we certainly see that quite frequently. 6 of 11, 55% had overt myopathy. Unlike the Japanese patients that are been previously and reported in MDA5, especially initially by Dr. Gono in Japan, our patients in the US tend to also get muscle involvement, has been our experience. And 8 out of the 11, 73% had ILD that are responsive to immunosuppression. I do want to put a plug-in for, not a plug-in, but a drug that we typically also use in our patients who tend to be more refractory in myositis and ILD. We do use tacrolimus. We do think it is more potent, as been reported. And there's been case series of efficacy and tolerability better than cyclosporin. And it has been reported in case series, again, of refractory anti-synthetase positive patients who have a better response. So in terms of the kind of treatment algorithm for myositis-associated ILD would be that you would start with steroids plus mycophenolate or azathioprine. And then if that patient is not responding, our experience in our center is to switch to tacrolimus. And we don't use really high doses of tacrolimus like they use for lung transplant. We don't start at like 5 milligrams twice a day and go 10, twice a day, 15. You know, we really use with low dose, and we're able to get away with that. You really don't need a lot. And again, plus or minus, if patients are having a flare on these oral agents or more refractory, I would say there is data. Dr. Sonia Danoff, we work with very closely. We worked on a project together with her pulmonary fellow where we looked at patients who did get IVIG in refractory cases, and they had improvement in their FVC and DLCO. So certainly IVIG is also used, and also rituximab has been also reported to have good results in ILD, especially those who have disease duration of less than 12 months or in an acute exacerbation. And lastly, going back to JAK inhibitors, there was a report in the New England Journal recently in 2019 about TOFA in MDA5 associated ILD. It was an open study of 18 patients treated with steroids and tofacitinib, but when they compared to those with controls, you can see their survival curve was significantly improved. It was quite striking. And when you look at their FVC and DLCO over time, from baseline to 6 months, you can see there's a big change in their FVC and DLCO as well. And they also had less infections in control. So I think this you may also see being looked at in a bigger study with ILD, myositis-associated ILD. So conclusions, treatment is really guided by the following key characteristics. I think, if you know the patient has different subgroups of dermatomyositis for immune-mediated necrotizing myopathy, our approach may be different, as I mentioned before. If they have an autoantibody, that will also help you guide treatment. Organ involvement, if there's more lung than muscle involvement, as I mentioned previously, you may choose the mycophenolate or azathioprine first as the steroid-sparing agent of choice. And combination treatments are really required in more refractory cases, and so I wouldn't be scared of using it. Just have to be very careful in monitoring their labs and checking in with the patient regularly. And I think the most novel treatments that are on the horizon are really in dermatomyositis. And I think that's exciting, and hope to update you on those things in the future. And thank you for your attention. And this is our Hopkins Myositis Center Team 2020. Very privileged to be working in this center, really led by our leader, Dr. Lisa Christopher Stein. But we also work closely with our neurologists and pulmonologists who we can lean on. And it's really multidisciplinary group, which is great to be in. If you have any questions, please my email. Oops, and I think that's it. Thank you.
Thank you so much for that great talk, Dr. Pak. We have a number of questions for you. The first one is about how do you kind of go about patients you're working up for either a muscular dystrophy or a metabolic myopathy, and what are some key features that kind of are red flags for you?
So when I'm thinking about muscular dystrophies, we always have to get the muscle biopsy. So for example, the classic kind of presentation to the clinic would be, I have refractory polymyositis, and actually I have a patient like this, and I've given a talk about like myositis mimickers, but she was 34 and was treated with every drug, rituximab, IVIG, methotrexate, mycophenolate, but her CK was still in the 5,000. And so when I saw her, number one, remember I gave you that list of evaluation, very good clinical exam. Someone with muscular dystrophy is not going to typically always just have proximal muscle weakness, in my experience. But of course, if it's a limb-girdle muscular dystrophy, it can be seen. So if the exam is going to guide you, right? And then also the EMG. The EMG can have myotonic discharges if they have a myotonic dystrophy, so the EMG could be potentially helpful. But again, EMG will not distinguish if someone has a muscular dystrophy or myositis, because they will also have an irritable myopathy because their muscle is very inflamed, CK is going to be really high, so when you insert that needle, you're going to have a lot of positive sharp waves and fits. which is the same for inflammatory myositis. Then, of course, a patient with muscular dystrophy, when you get their autoantibody panel, should be completely negative. So for patients with muscular dystrophy, the muscle biopsy is going to be really, really helpful. And there's some distinct features like instead of type 2 atrophy, you might see type 1 muscle atrophy. There are a lot of different things they can look at, so the neuromuscular pathologist can help you. If that's still not, giving you the answer, then you want to put your heads together. Maybe you want to do, genetic sequencing, to evaluate that further. For metabolic myopathies, sorry it's a long answer, but there are two kind of big questions there. For metabolic myopathy, you really want to do a forearm ischemic test. So you're going to have them exercise their muscle and then draw their blood and look at for these metabolites. And then that will help you. But again, when somebody has metabolic myopathy, they're going to have really high CK at some point and then completely normal. And if you did a biopsy on them, it's going to be necrotizing. So you never do a biopsy when they really have some high CKs because they're going to be misdiagnosed as a necrotizing myopathy. So I think you need to, and a muscle biopsy can certainly be helpful as well. Really need to work closely with the neuromuscular pathologist.
Great, thank you. There was a question about using EMG versus MRI versus both. How do you kind of differentiate when to use those modalities?
Yes, that's an excellent question. I think we have a little debate going on sometimes. And there's a lot of data. So the reason why I'm laughing about it is because if you ask a neurologist, they'll be like, oh, the EMG is definitely better, right? And then if you ask a radiologist, like, oh, no, the MRI is better. So I would say to localize for a biopsy. What is more helpful? It's hard to say. I think if you're really trying to go for the diagnosis, the EMG, I think, could be a little more helpful because it'll tell you if they have neuropathic involvement. I had someone with severe radiculopathy and a CK of 700. And he was in his early 40s and he was diagnosed with myositis. But it was not myositis. He just had a severe L5S1 radiculopathy, and that will raise your CK. And that was confirmed on the EMG. No myopathy. So in those kind of settings, the EMG can be helpful. Now, the MRI and EMG are both equally helpful when you're trying to decide where to go for a muscle biopsy, because you just go in the areas for the MRI where you have a lot of active muscle edema. And you can actually ask the radiologist, and we do this, please tell us where, from the knee, how many centimeters, deep and far away from the knee, can we, where should we locate and localize the biopsy? Because you will be actually telling the surgeon where you're going to go for the muscle biopsy, so you can tell them that using the MRI. I hope that answered the question.
I'll ask a question. First of all, this was a tour de force. Amazing. On the back end, we were compiling the questions, and I have never worked so hard in 40 minutes. There were so many questions. I'm going to group questions around steroids. So there were several questions around whether you have a prednisone regimen, a tapering schedule, whether you have a target at 6 months over the course of a couple of years. When you think about pulsing people, if you do that, perhaps you can just sort of address glucocorticoids in general, dosing, pulsing,
Sure.
and some taper schedule.
So pulsing is really for patients in the hospital, when they're extremely weak and they have dysphagia. I definitely pulse them. In the hospital setting. And then I immediately, let's say I met a patient in the hospital, then I'll go to prednisone 60 milligrams per day. Now, everybody is different with the prednisone taper, even within our center. I think that's going to be a given across all rheumatologists. But usually patients with a necrotizing myopathy, because those are typically the worst patients, I usually do 60 for 3 to 4 weeks, and then gradually taper by, every 10 milligrams every month. So I'm going to definitely put them on PCP prophylaxis, but immediately start again at the same time with the steroid sparing agent. And that's what I usually do for kind of necrotizing. Now, so it really depends on how severe their disease is. But if someone has dermatomyositis, then, and their skin is not that bad, I probably don't need 60, you know. So it depends on the severity of the skin. But I have gone from like 20 to 60, depending on how severe their skin is. But they really don't need as much steroids as necrotizing myopathy patients. So I hope that helps.
Great. And we wanted to see about, as far as doing cancer screening, how do you approach that? And do you have like a protocol in place for how you're screening patients?
That's a very hard question to answer. So when we see a new patient, we do get a CT chest, like one-time CT chest, abdomen, pelvis. And I remember one of our myositis group meetings, we were like, how much cancer did we really pick up? And really, we don't pick up that much. We've always questioned, is our cohort does not have a lot of cancer, but we may be missing it because we're biased and we're tertiary referral center. So definitely we say at least a one-time check at diagnosis. And if someone becomes refractory, then you know, we want to do the additional workup and maybe repeat it. I want to go back. I'm going to go back to that prednisone question. I think I didn't answer the one last question. Is once they're doing well, like with prednisone and you're tapering them on the steroid-sparing agent, my patients always ask me this question, you know, will I be able to get off the steroid-sparing agent? And I always give them hope because it is possible. So once they are off, and I want to just address the fact that if I say they're kind of in a chemical remission, so I really try to get them off within that first year of at least steroids if I can. It's not always the case, it may take a couple of years, but most of the time I'm pretty aggressive about trying to get them off the steroids. So after you go by 10 milligrams and you're hit to 20, then you go to either 15, 10, and then 5, and then, you know, you can go 5 to 0 or 5, 4, 3, 2, 1 by 1 milligram every 4 weeks. So hopefully that'll be done within that year or less, within the first 6 months to 12 months. And then if they're just on the steroid-sparing agent for 1 full year and they're doing well, I really say, oh, you're doing excellent. And really kind of this chemical-induced or medication-induced remission, your strength is strong, CK is normal, there's no skin rash, then I do start trying to taper. If I'm very confident that they're doing well after these follow-up visits, slowly they're either methotrexate, gradually, very, very slowly, or space out their IVIG more so that they can get off these steroid-sparing agents. Because that's like number one question I think I have from all my new patients. Okay, sorry, I digress, but that's, I think
this is good. Several people had questions about cyclophosphamide, plasmapheresis, thinking in these very refractory patients, what do you do when you've come to the end of your algorithm and patients have refractory disease like that?
Yeah, it's hard. It's very hard. I don't use Cytoxan regularly. I would have to say I really haven't. Maybe I used it once or twice. But if you've exhausted everything, certainly Cytoxan can be a possibility. Plasmapheresis, we do use that. So there is especially in our, I'm going to always kind of reference the necrotizing myopathy patients to be like the ones that are the most severe. And we sometimes do plasmapheresis in those patients. And this is not just unique to our center. Actually, I visited the Myology Institute in Paris for a conference. And when you hear about what they do, you know, in France, when they see myositis patients that are very weak, they actually do plasmapheresis from the beginning. It's like pulse plasmapheresis and the IVIG and all these things. So every, I guess, country has a different way to do it. But in our center, it's been those patients who are really refractory. We do sometimes admit for plasmapheresis. We have done that. And not so much as Cytoxan, but it can be used. And actually, Dr. Lisa Christopher and my other colleague, Chris McCoy, had looked at this in our center, and those people, those necrotizing patients who responded to high dose Cytoxan, were people actually who were HMGCR positive and who are statin exposed. So those who are statin naive tend to really not respond so much to high Cy.
I wish we could keep talking. We got through a fraction of the questions. Thank you for sharing your email. There were a lot of complicated cases presented in the questions. People have some really difficult patients that they're trying to manage. And so I would encourage this conversation to keep going. Absolutely. But we're at the hour, and I so appreciate the talk and my co-moderator and the ACR, of course, for hosting this fantastic series. Great. Thank you, everyone.
Thank you very much.
Thank you again.